Hello friends, welcome back. My name is Dr. Vijay Bhatia. Today we are going to talk about opioid intoxication. What are opioids? Opioids are a class of drugs that include the illegal drug heroin, synthetic opiates such as fentanyl, and pain relievers available legally by prescription such as oxycodone, hydrocodone, codeine, morphine, and many others. All opioids are chemically related and interact with opioid receptors on nerve cells in the body and brain. Opioids, pain relievers, are generally safe when taken for a short time and as prescribed by a doctor, but because they produce euphoria, that means feeling high, feeling well. In addition to pain relief, they can be misused, taken in a different way or in a larger quantity than prescribed, or taken without a doctor's prescription. Regular use, even as prescribed by a doctor, can lead to dependence, and when misused, opioid pain relievers can lead to addiction, overdose incidents, and even death. What is the mechanism of action of opioids? We are going to take a typical like morphine that will explain all the other opioids. They work similarly. Morphine is a competitive agonist at the µ-receptor, µ-opioid receptor, and is a potent analgesic. It is thought that activity at the µ1 receptor subtype may mediate the analgesic and euphoric actions of morphine, while activity at the µ2 receptors subtype may mediate respiratory depression and inhibition of gut motility. So inhibition of gut motility will cause constipation, and respiratory depression will slow down the breathing. Analgesic means relieving the pain. Euphoria means feeling well in themselves. And these are two receptors, µ1 and µ2. Where does these receptors are present, opioids? Because we mentioned they act through the receptors. These receptors are the gates within the cell membrane of the nerve cells and on the different areas of the brain. So they are present throughout the brain and also in the spinal cord. So this is the brain, this is the blood-brain barrier. It will pass through the blood-brain barrier and go inside the nerve cells. There is one area which we are going to talk a little bit more about in later slides, but it is just to highlight that it is present at the nerve endings, peripheral nerve endings. It is present inside the spinal cord. It is present inside the brain, and these are the opioid receptors at the endings and on the sides. Mu receptors. When we talked about these, mu receptors are present at the nerve endings, and the receptors present at the postsynaptic nerve ending for the next neuron. So one neuron communicates with the other neuron through the release of these neurotransmitters, which attach to the receptors present on the postsynaptic neuron, and they cause some kind of impulse there as an effect to take place. The important thing in any addiction, any dependence, any feeling of good, worth, happy, they are believed to play a role through a system in the brain called the reward system. Reward system is being affected by number of neurotransmitters. However, in this one we are going to talk mainly about our opioid reward receptors or reward pathway. In general, this is the ventral tegmental area of the brain, and this communicates with the nucleus accumbens, which is the main reward center inside the brain. This nucleus accumbens is being affected by number of other neuron inputs, either from the, in case of enkephalin is the opioid peptide which will affect the reward center nucleus accumbens in a positive way. And where does it come from? There is arcuate nucleus in the brain, which we believe produces, their nerve cells produce opioid-like products, which are called enkephalins. There are other ones as well, but here it is enkephalin, which is produced, which will stimulate the reward center nucleus neurons and tell them to produce the feeling of optimism, feeling high in the mood. This is also affecting the ventral tegmental area, because ultimately ventral tegmental area is affecting the reward nucleus accumbens. Through releasing the enkephalins in the ventral tegmental area, it is going to affect, even though this area is also being affected by other products like cannabinoids, like acetylcholine, like gamma-aminobenzoic acid or GABA, which is a naturally occurring neurotransmitter, and these affect the ventral tegmental area neurons. And another one is glutamate, which is coming from the hippocampus, amygdala, and prefrontal cortex. Now remember, this prefrontal cortex, this is the part of the brain which is working with the planning, judgment, and forward thinking, and amygdala is the main part of the emotions, fear, danger, identifying that and telling the person, and hippocampus mainly to do with the memories. So all these things are being affected. The reward center is being affected from one way or the other way. But today we are focusing on the arcuate nucleus. The neurons in the arcuate nucleus will send the axons to the nucleus accumbens, and also it will send axons to the ventral tegmental area, thereby affecting the neurons in the ventral tegmental area, ultimately leading the effects on the nucleus accumbens. The final common pathway of reward in the brain is hypothesized to be the mesolimbic dopamine pathway. This pathway is modulated by many naturally occurring substances in the brain in order to deliver normal reinforcement to adaptive behaviors such as eating, drinking, sex, and thus to produce natural highs, such as feelings of joy or accomplishment. These neurotransmitters inputs to the reward system include the brain's own morphine or heroine, we call them endorphins, such as enkephalin. The brain's own cannabis or marijuana, called anandamide. the brain's own nicotine, called acetylcholine, the brain's own cocaine or amphetamine, dopamine itself. The numerous psychotropic drugs of abuse that occur in nature bypass the brain's own neurotransmitters and directly stimulate the brain's receptors in the reward system, causing dopamine release and a consequent artificial high. The alcohol, opioids, stimulants, marijuana, benzodiazepines, sedative hypnotics, hallucinogens, and nicotine, they all affect this mesolimbic system, producing the artificial high. Therefore, all of these external products can be quite addictive. Person wants to take more of these again and again to get that artificial high. Endogenous opioids that we talked about are produced inside the brain, inside the nerve cells. Opioids act as neurotransmitters released from neurons that arise in the arcuate nucleus and project to the ventral tegmental area and to the nucleus accumbens and release enkephalin. Naturally occurring endogenous opioids act upon a variety of receptor subtypes. The three most important receptor subtypes are mu receptors, delta receptors, and kappa receptors. These receptors, this is the cell membrane. These receptors are present there. This will be mu, the other one will be kappa, the other one be delta. These are all the opioid receptors, and even with the mu, as we discussed earlier, they can be mu1 or mu2. And the brain makes a variety of its own endogenous opioid-like substances, sometimes referred to as brain's own morphine. These are all peptides derived from precursor protein called pro-opiomelanocortin, or in short, POMC. There's another one, peptide, pro-enkephalin and prodynorphin. All these parts of these precursor proteins are cleaved off, cut off, to form endorphins, enkephalins, and dynorphins. These are stored in opioid neurons and presumably released during neurotransmission to mediate endogenous opioid-like actions, including a role in mediating reinforcement and pleasure in reward circuitry. Exogenous opioids in the form of pain relievers such as oxycodone, hydrocodone, and many others, or drugs of abuse such as heroin, are also thought to act as agonists at mu, delta, and kappa opioid receptors, particularly at mu sites. At and above the pain-relieving doses, the opioids induce euphoria, which is the main reinforcing property of the opioids. Opioids can also induce a very intense but brief euphoria, feeling very high, sometimes called a rush, followed by a profound sense of tranquility, which may last several hours, followed in turn by drowsiness, sometimes called nodding, mood swings, mental clouding, apathy, and slowed motor movements. In overdoses, these same agents act as depressants of respiration and can also induce coma. So what is the acute intoxication? If somebody takes too much, there will be apathy. They don't want to do anything. They're just sitting there. They feel sedated. They just want to lie down and sleep, not to be disturbed. Or there might be disinhibition, psychomotor retardation. They don't want to move. Their movements are really slowed down. Walking, talking, and even their arm movements, they are very slowed down. They have poor attention. They have poor judgment, and their personal functioning is quite impaired. And one of these must be, or two of these must be present: drowsiness, slurred speech, pupillary constriction. Opioids produce constriction of the pupil, except in anoxia from severe overdose when there is a pupillary dilatation. Decreased level of consciousness. Example, they might be in stupor or coma. They are not responding to anything, either to speech or pain. If it is very severe intoxication, they can have a respiratory depression. Respiration will be very slowed down, and therefore the oxygen going to the brain and to the vital organs will be very less and causing confusion. And there might be hypothermia. The temperature, body temperature may become so low, below even sometimes 35 degrees Celsius, which can be quite dangerous. The other important bit is the opioid withdrawal symptoms. If the person is taking opioids for some time and they miss the doses or they can't obtain those opioid drugs, then they will start getting withdrawal symptoms. And any of these three must be present in order to fulfill the criteria of withdrawal symptom. There is a very strong craving for an opioid drug. There might be runny nose or sneezing. There might be watering eyes, lacrimation. They may suffer from muscle aches and cramps, abdominal cramps, nausea and vomiting. There may be diarrhea, pupillary dilatation, as we talked about earlier. However, if it is very acute, toxic doses are taken, there will be pupillary dilatation. And now remember, if the person is taking opioids, morphine, then their pupils will be small. Now they are not getting the morphine, their pupils will be dilated. Piloerection, the hair on the skin, they become quite as if they are frightened, as if they are scared. They get erect, the hairs on the arms and legs and even chest. Or they get recurrent chills, tachycardia, high pulse rate and high heart rate, hypertension, high blood pressure, yawning. They keep on yawning, and they might feel that they are having restless sleep. They can't sleep properly. Dependence develops when given chronically. Opioids readily cause both tolerance and dependence. Adaptation of opioid receptors occur quite readily after chronic opioid administration. The way the human body is, it wants balance. It has to be balanced, everything. If we take any drug from outside, it upsets that balance, and the body wants to create that balance. So adaptation occurs within the receptors, opioid receptors, quite readily. And so if the balance is tipped this way, that the person is getting high when he's getting the drugs from outside, if they don't get the drugs, they will suffer. The body is asking more of these. The first sign of this is the need of the patient to take higher and higher doses of opioid in order to relieve pain or to induce the desired euphoria, feeling of well-being. If not taken regularly, then withdrawal symptoms develop with dysphoria. Dysphoria is opposite to the euphoria, where the feeling is as if quite bad, feeling worse, and there will be strong craving for another dose, and they will feel irritable, and they will be having signs of autonomic hyperactivity, as we discussed earlier, with the heart racing and tachycardia and sweating. Opioid antagonists such as naloxone and naltrexone, they are used if somebody has developed acute intoxication. This can be reversed by giving these medications. Naloxone, they come as injection, so this can be given, but should be given in the controlled environment in the hospital where all the facilities for resuscitation are available. Well, thank you for listening and watching this video. If you like this video, please press the like button, share with others, and subscribe the channel. There are other videos on alcohol, benzodiazepines, hallucinogens, and other videos on the mental disorders. I see you again in my next video.